Hello, everyone. My name is Annie Zhu. I'm a fourth-year resident with us, and my topic for our neuroanesthesia rounds today is neuroprotection strategies and improving perioperative brain health. This has been a topic of interest for surgeons and anesthesiologists for many years. We all want the best clinical breakthrough in neuroprotection, and many pharmacological and physiological interventions have been tried in animal and human models. However, only some have stood the test of time. So it's a big topic, and it's a topic that requires a lot of ongoing research. So for the first part of my presentation, I will go over some fundamental neuroprotection strategies that have been used over the years and talk about some limitations with its use. And for the second part of the presentation, I will talk about a very hot subject right now, which is perioperative brain health. The American Anesthesiology Society have worked with a group of expert panels to come up with a consensus statement on how we as anesthesiologists can optimize cognitive recovery and perioperative experience. And I think us as anesthesiologists, especially the neuroanesthesiologists that are listening, have a key role to play in this. So to start out with, for cerebral ischemia and hypoxia, as we all know, it can occur in a variety of perioperative circumstances. And the clinical outcome of this vary from subclinical neurocognitive deficits all the way to very catastrophic neurological morbidity or death. A couple of mechanisms that this could happen. It could be embolic, such as atrial fibrillation, MI, vascular disease. It could be from an iatrogenic embolic cause, from, for example, air, plaques, thrombus. It could be iatrogenic non-embolic source, such as hyperthermia, hypertension, or PaCO2 management. Or it could be from an ischemic source, such as using retractors, or putting pressure from them, hypotension, hemorrhage, vasospasm, temporary clipping to elevated ICP. It has become increasingly clear that an ischemic or hypoxic insult does not simply constitute an energy failure with subsequent interruption of ongoing metabolic events. Ischemia or hypoxia stimulate active response in the brain, which persists long after substrate delivery has been restored. And these responses include activation of transcription factors, which upregulate expression of genes contributing to apoptosis and inflammation, inhibition of protein synthesis, sustained oxidative stress, and neurogenesis. And most of these responses aggravate damage caused by the primary insult. As the concept of neuroprotection needs to be extended well into the reperfusion phase. And targeting events such as apoptosis, oxidative stress does offer very promising future clinical trials. A lot of our interventions today to reduce perioperative brain injury has been based on extrapolation from animal studies. And this table, created by Fukada and his group in 2007, illustrates how these interventions that were initially promising in animal studies often do not translate well into human studies due to various limitations. I've highlighted those in yellow, some interventions that did show promising results in human trials. And to explain the table, 1 plus equals evidence of benefit. If you see 2 plus signs, that means there's repeated physiological control studies in animals or randomized prospectively adequately powered clinical trials that show benefit. And if you see a plus minus, this means inconsistent findings. If you see 1 minus, it means there's an absence of benefit. And if you see 2 minuses, there's an absence of randomized, from randomized prospectively adequately powered clinical trials. And if there's 3 minuses, there's actually evidence of harm. So as you can see, lots of mechanisms have been investigated in the past, starting out from animal studies. However, not all translated well to human trials. So going in detail now about some of the popular neuroprotective strategies. Of course, we can't start without saying that aggressive medical therapy is very important. because a lot of these modifiable risk factors, such as patient hypertension, atrial fibrillation, diabetes, recent MI, are higher risk of contributing to perioperative stroke and perioperative ischemia as well. So aggressive medical management of these is very helpful. In terms of barbiturates, it has been postulated for a very, very long time that barbiturates have a role in preventing brain from ischemic insult. And the logic was that the anesthetic agent suppresses neurotransmission and hence reduce energy requirement. And if it's given before the onset of ischemia, it could delay decay of ATP concentrations. And many studies have shown that barbiturates do slow deterioration of ATP concentrates, and cerebral lactate was significantly less. Post-ischemic treatments with barbiturates or volatiles unfortunately had no effect on outcome, and human studies in this field is still yielding mixed results. They're often either uncontrolled or flawed. For example, the study by Nesmir showed that thiopentol reduced neuropsychiatric abnormalities in cardiac surgery patients. However, the study did not have a proper temperature control. And then follow-up study by Zidan and his group showed there's actually no benefit. So some practitioners still use barbiturates to protect the brain, but the clinical application of this has been limited given that large doses do cause depression of cardiac output, increased liver enzymes, increased risks of cardiac arrhythmias, lower immune thresholds adversely affect brain temperature, systemic hypotension, and dyskinemia. So volatile anesthetics, it's another one. Animal studies have shown benefits for isoflurane and sevoflurane in particular. It's thought that volatile anesthetics protect against focal and global ischemia. An improvement in outcome is transient in global ischemia, where it is persistent in focal ischemia. And the proposed mechanism is that the volatile anesthetics suppress energy requirements. It can inhibit excitatory neurotransmission and potential of inhibitory receptors, and also has a role in regulation of intracellular calcium responses and potassium channels during ischemia. However, there's only a human outcome data regarding the use of volatile anesthetics, and so a lot of investigation still needs to be done. Other anesthetics that are shown to be neuroprotective to some degree include propofol, etomidate, and lidocaine. They all suppress, the mechanism is thought that they all suppress CMR, and especially propofol, also free radical scavenging and anti-inflammatory properties as well. However, these drugs do have its limitations. For example, propofol, dose-dependent study of efficacy are needed to guide its clinical use. In etomidate, the drug is found to exacerbate ischemic injury by inhibiting nitric oxide synthase, therefore intensifying ischemic insult. And then lidocaine, some of its limitation is that the dose required to suppress cerebral metabolic rate only occurs at doses that's way too high and far beyond those that's typically used in clinical environment. So there's actually a very large body of evidence to suggest that temperature regulation induces hypothermia and can limit or reduce primary injury and prevent secondary injury in animal models of brain insult and certain clinical settings. Hypothermia affects a lot of pathways leading to excess toxicity, apoptosis, inflammation, free radical production, as well as role in blood flow, metabolism, and blood-brain barrier. It's also thought to influence neurogenesis, gliogenesis, and angiogenesis following injury. So it has hypothermia affects many of these pathways. And it is likely that there's no single factor that can explain the neuroprotection provided by hypothermia. And so targeted temperature management, or TTM for short, for neuroprotection, involves maintaining the temperatures of the brain at predetermined levels by various techniques. It is aimed at avoiding the harmful effects of hyperthermia on the brain and exploiting the protective effects of lowering tissue at temperature. And there has been an explosion in the use of target temperature management for neuroprotection in a variety of clinical scenarios, apart from the commonly accepted fields of resuscitation, ischemia, and hypoxic encephalopathy. So traditionally, TTM is considered you cool the brain to 32 to 34 degrees Celsius in patients who don't regain consciousness after ROSC following cardiac arrest. But nowadays, targeted temperature management refers to maintaining the brain temperature at a predetermined level, whether that's mild hypothermia from 33 to 35 Celsius, or actually induced normothermia, so cooling a hyperthermic patient. So it's very, like I mentioned before, it's useful in a variety of clinical settings. First major step was made with demonstration that rapid induction of mild sustained hypothermia in comatose survivors of out-of-hospital ventricular fibrillation cardiac arrest reduces death and neurological morbidity with negligible adverse events. And it was these studies were the first irrefutable evidence that outcome can be favorably altered in humans with widely applicable neuroprotection protocols. And mild hypothermia is widely used in the treatment of successfully resuscitated patients after cardiac arrest. As we know, there's 2 landmark studies in 2002 that demonstrated the use after cardiac arrest to ventricular fibrillation, decreased mortality, and improved a neurological outcome. And in the area of neuroprotection, it's also useful in traumatic brain injury, spinal cord injury, acute ischemic stroke, intracranial hemorrhage as well. So in traumatic brain injury, the Brain Trauma Foundation guidelines summarize that prophylactic hypothermia may improve outcome if maintained for 48 hours more, but lack in clear mortality benefits. In spinal cord injury in animal models with spinal cord injury, improvements in functional outcome have been associated with cooling and have been reported, and hypothermia have been shown to increase the duration of ischemia required to reduce neurological deficits. So hypothermia appears to be a promising treatment in this population. But still larger scale human studies is needed in the area of spinal cord injury. For acute ischemic stroke, they have considered targeted temperature management. However, the data right now coming from clinical trials, it's still lacking and there's insufficient evidence. There's definitely a lot of trials going on looking into this. So we'll stay tuned to see how it could be beneficial or not in acute ischemic stroke. And in terms of intracranial hemorrhage, experimental data do indicate that targeted temperature management is neuroprotective after intracerebral hemorrhage and reduces perihemorrhagic edema. Unfortunately, there's no large-scale data to recommend its use in hypothermia in this group, but again, a few studies are coming. And for cooling in the operating room, in a recent Cochrane review of cooling for cerebral protection during brain surgery involving 1,219 patients, the author found that no evidence that hypothermia was either effective or unsafe when compared to normothermia. It's also targeted temperature management is also very useful for hypoxic encephalopathy in the neonatal group, where it's proven to be beneficial, especially in term neonates after a hypoxic ischemic encephalopathy, and in children with traumatic brain injury. Glucose is another neuroprotective strategy. So as we all know, it is a fundamental substrate for brain energy metabolism. And intraoperative hyperglycemia is very common in adults and children undergoing urgent and emergent craniotomy for traumatic brain injury. And that intraoperative hyperglycemia during neurosurgical procedures have been linked to more likely to develop postoperative neurological dysfunction, more likely to exacerbate tissue acidosis and lactate degeneration, and exacerbate secondary neuronal injury. Also associated with more rapid expansion of ischemic lesions. In a retrospective examination of 1,000 patients from the intraoperative hypothermia for aneurysm surgery trial database, so the IHAST, who underwent aneurysm clipping within 14 days of subarachnoid hemorrhage. The investigators noted that 3 months after surgery, those with a glucose level greater than 129 milligrams per deciliter were more likely to have impaired cognition than those with glucose greater than 152. And they were more likely to experience gross neurological dysfunction as assessed by the National Institute of Health Stroke Scale. And in another retrospective cohort study of 170 patients admitted to the ICU with traumatic brain injury, so GCS equal or less than 8, episodes of hyperglycemia, which was classified by glucose greater than 11.1 millimoles per liter during the first 10 days after injury, was associated with the 3.6-fold greater increased risk of in-hospital mortality. So more at the present, more studies is needed to define what the optimal glucose range looks like, because we know that hyperglycemia is associated with harm. However, hypoglycemia is associated with harm as well. So the general consensus right now for neuroprotection is to recommend keeping the glucose less than 10 millimoles per liter in traumatic brain injury patients. So the next one is PaCO2. We know that hyperventilation is frequently used in neurological patients based on the fact that hyperventilation-induced hypocapnia has profound effects on cerebral physiology. And it's well known that CO2 is a powerful modulator of cerebral basal tone, and hypocapnia leads to cerebral vasoconstriction, whereas hypercapnia causes cerebral vasodilation. And we use hyperventilation to decrease elevated ICP and relax intense brain because hypocapnia leads to reduced cerebral blood flow and cerebral blood volume, and appears to be well tolerated when applied to relax uptight brain during craniotomy. Hyperventilation, however, its effects on neurological outcomes in patients with TBI or intracranial hemorrhage still remain somewhat unclear. Randomized controlled trials performed in patients with severe head injury suggests that prolonged prophylactic hyperventilation may be deleterious. And one major concern with forced hyperventilation is hypocapnia-induced cerebral blood flow reduction, prolonged prophylactic hyperventilation with arterial CO2 tension less than 25 millimeters or during the first 24 hours after injury is not recommended. And a systematic review based on 6 studies concluded that both hypocapnia and hypercapnia after cerebral injury are more associated with poor patient outcomes. And then in terms of for hemorrhagic stroke, there was one study that showed the duration, so 7 days of hypocapnia was associated with unfavorable outcomes and symptomatic vasospasm, but the ICU length of stay and hospital mortality were not associated with this duration. In another retrospective study performed in over 1,000 patients with endovascular coiling or surgical clipping of subarachnoid hemorrhage found that neither blood pressure nor end-tidal CO2 as defined by less than 30 milligrams of mercury was significantly associated with the GSC scale at discharge or 3 months after discharge. So as we can see from these trials, that hyperventilation is certainly a double-edged sword, and it brings both benefits and risks. So hyperventilation can rapidly reduce ICP and relax the brain. However, it also decreases the cerebral blood flow in both normal and injured brains. And the therapeutic effect and the deleterious effect associated with hyperventilation should definitely be balanced when we're trying to make a decision on whether or not to use this. So the best way to use this in the neurological patient still needs a lot of further research. Steroids has been another area that was investigated in the past as a potential neuroprotective mechanism, as glucosteroids can reduce edema surrounding brain tumors. However, there's insufficient evidence to define its roles in focal ischemic stroke. And some studies show that there's no benefit of glucocorticosteroids in treatment in patients with cardiac arrest. In fact, animal studies suggest steroids may exacerbate injury from global ischemia by increasing plasma glucose concentration. So outside of reducing the edema for surrounding brain tumors, its neuroprotective strategies for other areas still needs to be investigated. So as you can see, a lot of interventions have been tried in the past. And a lot of research, especially large-scale human trials, are still needed. And certainly using a combination of these strategies is better than solely relying on one. And a lot of strategies I mentioned earlier are more applicable to neural surgery. So you might be asking, outside of neural surgery, what can we do to improve perioperative brain health? And a lot of what we can do is in the area of optimizing cognitive recovery. So the area of delirium delirium and perioperative neurocognitive disorders. They're actually very, very common, and they're most common complications in patients greater than 65 years old. And at present, I can speak for myself. I certainly very seldomly screen for, document, or discuss the risk for perioperative neurocognitive disorders with patients and their families, even though delirium and other complications are much more common than complications such as MI. It's important to know that it is preventable in up to 40% of patients. And ASA, so the American Society of Anesthesiologists, has worked very hard to develop a perioperative brain health initiative to bring patient safety initiative as a patient safety initiative to optimize cognitive recovery and perioperative experience for adults over 65 years old undergoing surgery. And I think as us anesthesiologists, we should be a key player and key leader of multidisciplinary clinical team to help improve the management of these perioperative neurocognitive disorders. So I want to take the next few minutes just to share some slides and outcomes from their recommendation. So a lot of the recommendation comes from this paper called Improving Perioperative Brain Health, an expert consensus review of key actions of the perioperative care team. It was published by the BJA recently. So the authors gathered an international group of experts, and they were reviewed published best practice statements and guidelines. And the group was aimed to achieve consensus on a small number of practical recommendations that could be implemented by anesthesiologists and their partners to reduce the incidence of perioperative neurocognitive disorders. Ultimately, 6 statements were selected, and they were selected because of their potential for impact, the strength of the evidence, as well as feasibility of widespread implementation, even in resource-poor healthcare settings. So in terms of the key action, number 1, it's surrounding education and training. So a multidisciplinary team, including but not limited to anesthesiologists, surgeons, nurses, pharmacists, and geriatricians, should work together to develop education and training programs to, one, support identification of risk factors for delirium and other perioperative neurocognitive disorders, and to discuss the risk for delirium, techniques to minimize delirium developing and potential delayed return to baseline thinking and memory with patients and their families, and to, three, manage a patient with delirium. And this is the handout they created for anesthesiologists and surgeons to give patients. And this could be downloaded on the website and could be easily given to them to help inform them. Key recommendation number 2 is regarding cognitive screening. So in at-risk patients, conduct or direct the conduct of, 1, a baseline cognitive screening using a validate test, and 2, an assessment of additional risk factors for PND. And the simple validated tool that has been proposed is the MiniCog. Some of you might have used this before. And it's the tool that's strongly recommended as a tool of choice in the best practice of guidelines from the American College of Surgeons and the American Geriatric Society. It's very easy tool to use, and it doesn't take a lot of time. And it's important to document baseline status before surgery to identify who's at risk and to track who's at risk as well. So key recommendation number 3 is around screening. So monitor at-risk older surgical patients by ensuring a baseline delirium screen before surgery in patients undergoing emergency surgery, and for all patients before discharge from the recovery room, and then ideally twice daily until day 5 for discharge using a validated screening tool. And commonly used screening tools, including the 4A's test, which scores arousal, attention, abbreviated mental tests, and any acute change, and the CAM test, so the confusion assessment method. And the frequency of assessment should take into account patient risk and clinical setting. So key action number 4 is regarding non-pharmacological interventions. So partners with healthcare professionals and family in the hospital to implement multi-component non-pharmacological intervention to prevent delirium. Program should be delivered by an interdisciplinary team for the entire hospitalization, targeting at-risk surgical patients for the purpose of delirium prevention. And then so the examples of non-pharmacological interventions could include mobilization, orientation, communication, physiotherapy. And practical things that we can do to help is returning cognitive aids immediately after surgery, such as returning glasses, hearing aids. And then for nursing to protect sleep-wake cycles with quiet hours, dark rooms, earplugs, and etc. Key action number 4 is surrounding pain control. So work with surgeons and other clinicians to optimize post-operative pain control, preferably with minimally sedating multimodal pain management. As we all know, older adults are more sensitive to opioids. So our multimodal pain management should be used whenever possible, and should include routine use of paracetamol and NSAIDs if appropriate, not contraindicated, and local anesthetics blocks or infiltrations. And PCA is an option if the patient is able to titrate the medication. Delirium is not necessarily a contraindication to using a PACA. And the next key action, last but not the least, is surrounding antipsychotics and anxiolytics. So we want to avoid antipsychotics and benzodiazepines for first-line treatment of delirium, unless benefits such as drug and alcohol withdrawal management far outweighs known risks, and there is an active risk of harm to the patient or the staff. And for the first-line management of patient with delirium, clinicians just seek to involve family, reorientate the patient, and provide necessary hearing and visual aids, minimize pain and treat other sources of discomfort before resorting to these pharmacological options. And this approach should be communicated to all healthcare professionals throughout the stay. So those were the key action steps recommended by the ASA and the Perioperative Brain Health Initiative to help improve a perioperative brain health and decrease perioperative delirium. I think we have a huge role to play in this. And I'll definitely be actively trying to screen these and next time I'm on call. So thank you for bearing with me today. And to summarize, we talked about neuroprotection strategies, including pharmacological interventions such as barbiturates, volatiles, other anesthetics such as propofol, etomidate, lidocaine, and then physiological interventions such as temperature, glucose, PaCO2, and steroids. We have come a long way in studying animals and human models and how it helps neuroprotection, but still lots of human trials need to be done to help us further understand this field.